Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam, and today we are going to look at the ACC/AHA Stemi Guidelines 2014. As of 2017, these are the latest guidelines for managing patients with Stemi. So let us begin. Here's a chart which sort of simplifies how we manage patients with an acute STEMI. If a patient presents with a STEMI who is a candidate for reperfusion, the question is, does your facility have reperfusion provisions, or do you have to transfer the patient to a tertiary center for coronary intervention? If your institution has no PCI facilities, then if this patient cannot be transferred to a PCI facility within a reasonable amount of time, that is from the first medical contact to device time, which should be less than 120 minutes, then these patients should be transferred to the PCI receiving hospital where they can undergo cardiac catheterization and coronary interventions as indicated. If the time involved is greater than 120 minutes from the time this patient first arrives at a non-PCI facility, then these patients must be considered for thrombolytic therapy. If the thrombolytic therapy fails and if the patient continues to have symptoms, then we should again consider transferring this patient to a facility that has PCI provisions, which can help to intervene in an invasive procedure. On the other hand, if your institution has PCI capabilities, then the patient should be transferred right from the emergency room to the cardiac catheterization lab where they undergo coronary intervention if that can be accomplished within the first 90 minutes from the time the patient arrives at the emergency department. A cardiac catheterization is performed and a target vessel coronary intervention is performed as indicated, and if the patient has more significant coronary artery disease along with other complications we are going to talk about, then the patient can go for urgent coronary artery bypass surgery. On the other hand, if the lesion is not significant enough for coronary intervention, then these patients can be treated medically. So this is a broad outline of how we manage the patients in the emergency room once they arrive with a STEMI, depending on whether your facility has PCI provisions or not. Now let's get down to the real guidelines as far as each individual scenario is concerned. Regional system of STEMI care, reperfusion therapy and time to treatment goal. Class 1A indications. Reperfusion therapy should be administered to all eligible patients with STEMI with ongoing symptoms within the first 12 hours. So if the patient comes to your institution and you have PCI services available, if they are having a STEMI and if they are having symptoms, they can undergo coronary intervention within the first 12 hours of the presentation. Again, 1A indication, PCI is the recommended method of coronary reperfusion if it can be performed in a timely fashion, as I already explained. If your institution does not have PCI capabilities and if this patient has to be transferred to a PCI facility for management of STEMI, then if you keep the first medical contact to device time to less than 90 minutes, then this patient should be transferred to the PCI facility where they can undergo cardiac catheterization and coronary intervention as indicated. Again, there's a little confusion as far as I'm concerned. Here they say 90 minutes, and the previous slide they said FMC to device time as 120 minutes. So I'm not clear as to which one they are referring to. However, if you are taking a board exam, you should keep these two numbers in mind depending upon what they are giving, so that you can realize that if the patient cannot undergo PCI in less than 120 minutes, then those patients should be considered for thrombolytic therapy at the institution where they arrive to begin with. On the other hand, if you are not able to transfer a patient to a PCI facility within 120 minutes, then these patients must be considered for fibrinolytic therapy, and that is 1B indication. Let's say you are in an institution and you do not have PCI facilities, and the PCI facilities are available only 3 hours from your institution. In that situation, these patients should be considered for fibrinolytic therapy, which is a 1B indication. And if you decide to treat these patients with fibrinolytic therapy, after you have excluded the long list of contraindications, the fibrinolytic agents should be administered within 30 minutes of hospital arrival. That's an important point. They may ask you a question on that. However, 2B indication says that reperfusion therapy is reasonable for patients with Stemi and symptom onsets within 12 to 24 hours if they are having ongoing ECG or clinical evidence of ischemia. In other words, you can consider thrombolytic therapy if they are having ongoing ischemia, but a more prudent thing would be to transfer these patients to a PCI facility rather than waiting for 12 to 24 hours trying to use fibrinolytic agents. All right, now let's move on to patients with Stemi and out of hospital cardiac arrest. How do we manage these patients? Here is a very important point I would like to bring out. Those Stemi patients who have out of hospital cardiac arrest caused by VFib or pulseless VT should not only undergo primary PCI, but they should also be treated with therapeutic hypothermia. A key word to remember is therapeutic hypothermia. You may get a question on this one. Immediate angiography and PCI is indicated for patients resuscitated out of hospital cardiac arrest whose initial EKG shows Stemi. So this is a no-brainer. You know that. If you have a patient with cardiac arrest and the EKG shows Stemi changes, these patients need to be taken to the cardiac catheterization lab for cardiac catheterization and coronary intervention if indicated. Now let's talk about primary PCI in a Stemi. If you are at an institution where primary PCI can be performed on these Stemi patients, and here are the guidelines. 1A indication is PCI should be performed in patients with Stemi and ischemic symptoms of less than 12 hours duration. Again, these durations are getting more and more complicated and confusing. First, they say it should be within the first 90 minutes. Then they say you can do this in less than 120 minutes if you can transfer a patient from a facility where there is no PCI available. And then if you are in a PCI institution, they say you can perform PCI in these patients with Stemi if they are having ongoing ischemia of less than 12 hours duration. So if a garden variety Stemi patient shows up, your goal is to obtain coronary perfusion within the first 90 minutes. But if the patient for a reason does not get a PCI and they continue to have ischemic symptoms and they can undergo cardiac catheterization and PCI up to 12 hours of duration of these symptoms. That's what it means. Here's 1B indication. Primary PCI should be performed in patients with Stemi with ischemic symptoms of less than 12 hours duration who have contraindications for fibrinolytic therapy irrespective of the time delay from the first medical center. So what it means is, if a patient arrives at a primary care hospital and they do not have facilities for PCI, and if the patient is having ongoing symptoms, they should be transferred to a PCI facility even if the patient had symptoms for 8 to 12 hours, and they should be considered for cardiac catheterization and PCI. Then again we have another 1B indication where it says primary PCI should be performed in patients with Stemi and cardiogenic shock, acute heart failure, irrespective of the time of onset. So they may trick you with a question saying that this patient presents with acute pulmonary edema, he had chest pain for 6 to 8 hours, this patient is having ongoing chest pain for almost 8 to 10 hours. What would you do? You take the patient to the cardiac catheterization lab and consider coronary intervention. So that's what they are looking at. How well do we interpret these guidelines in managing patients with the STEMI? Now here is a contraindication. 3B, that means contraindication. Just a word about these guidelines. We should know most of the guidelines for any given cardiovascular disease entity, such as STEMI or valvular heart disease or cardiac arrhythmias. We should know 1A, B indications, which are the high level indications for that particular entity. We should also know class 3 A, B indications, which are mostly contraindications in any given disease entity. Now let's look at 3B. PCI should not be performed in a non-infarct artery at the time of the primary PCI in patients with the STEMI who are hemodynamically stable. This is a situation where it is very tempting. You got an anterior infarct with a 100% occlusion of the LAD, and you successfully perform the coronary intervention. Then you see a 90% mid RCA lesion, and you think, yeah, I can do this in 10 minutes. I can get the wire and put the balloon and stent in 10 minutes, will be done. But hold it. According to the ACC/AHA guidelines, it is not indicated for this patient to undergo coronary intervention of a non-infarct artery. At least that's what you have to think when you're taking a board exam. In the real life, what people do are different. Okay, let's look at what kind of stents do we use in patients with the STEMI. And of course, placement of stents is useful in primary PCI patients with STEMI. What we are saying is not just simple balloon angioplasty, but placing stents in patients with acute STEMI is a 1A indication. That means in most patients, unless you can't get the stent for technical reasons, they should have a stent. The next question comes up, do they get bare metal stent or do they get drug-eluting stents? There are two scenarios where we make this differentiation. Number one, we put bare metal stents in patients who cannot take dual antiplatelet agents for a whole year for any number of reasons, such as they are going for a surgical procedure within the first year, a surgery that cannot wait. In those situations, we have to put a bare metal stent. When we put a bare metal stent, they need to be on dual antiplatelet agents for a minimum of 4 weeks before they are considered for surgery. However, if we put a drug-eluting stent, then these patients need to wait for at least a minimum of 1 year before they can be safely operated on by withholding the dual antiplatelet agents. Again, here's a contraindication for using drug-eluting stents. Under what circumstances would we not put a drug-eluting stent in a patient with STEMI? Those patients would be who cannot tolerate dual antiplatelet agents because of significant bleeding problem, or those patients who are so non-compliant that you don't think they are going to take dual antiplatelet agents, then these patients should not get drug-eluting stent because the risk of intra-stent thrombosis is exceedingly high in the first year after the placement of a drug-eluting stent, either in STEMI or in elective cases. Now we are going to move on to antiplatelet therapy to support primary PCI for STEMI. Doing a PCI is just one of the elements in managing a patient of a STEMI where there are multiple agents involved. Putting a stent is a mechanical process. After that, we have a lot of things that we need to take into consideration and those include antiplatelet agents, anticoagulants, statins, beta blockers, and other supportive measures in patients with complications resulting from acute myocardial infarction. Aspirin, every one of us know that we need to use aspirin. There's no question about this. In fact, the aspirin should be given in the ambulance before even these patients arrive at the emergency departments. If for any reason they don't get aspirin, they should receive 165 to 325 milligrams of aspirin before the primary PCI. This is a class 1B indication. Class 1A indication is that these patients who undergo PCI should be on aspirin indefinitely. They may question you on this one. How long do they stay on aspirin? 6 months, a year, or indefinitely? The answer is indefinitely. Along with the aspirin, we also use antiplatelet agents for long-term management of patients who receive either drug-eluting or bare metal stent. The most commonly used antiplatelet agents, which most of you are familiar with, are in the class of P2Y12 receptor inhibitors, which act on the platelets, and the drugs available today are clopidogrel, which is given as a 600 milligram bolus, or prasugrel 60 milligrams, or ticagrelor 180 milligram. That is at the time of the PCI. The question comes up, you're seeing a patient with Stemi in the emergency room. Now you're taking this patient to the cardiac catheterization lab for cardiac catheterization and coronary intervention. Do you or don't you load this patient with 600 milligrams of Plavix, or 60 milligrams of prasugrel, or 180 milligrams of ticagrelor? Think about it. What if this patient has to go for surgery? The risk of bleeding becomes exceedingly high if these patients have to go for surgery. So, what is the rational approach? If you are dealing with a STEMI, what is the anatomy we find in the cardiac catheterization lab? Most likely 100% occlusion of a coronary artery. And if you have a 100% occlusion of a coronary artery, then it cannot get any worse. But by giving this drug, if the patient has to go for surgery, we are really facing the risk of significant postoperative bleeding. So my principle is take these patients to the cardiac catheterization lab, and once we have established this patient needs PCI and nothing else, then immediately after the procedure, these patients can be started on antiplatelet agents. This is generally after the PCI is completed, because as soon as we have the catheters in these patients in the cardiac catheterization lab, we are giving them antithrombin drugs which act within minutes and prevent any significant coagulation or clot formation within the intravascular system. So it is important to understand the adverse effects of drugs before we put them into the patient's body system. All right, we talked about acute antiplatelet management immediately following PCI, and this is a long-term management of antiplatelet agent. All patients undergoing PCI for STEMI should receive these antiplatelet agents, namely clopidogrel 75 milligrams daily, or prasugrel 10 milligrams daily, or ticagrelor 90 milligrams twice a day for a minimum of 1 year, along with 81 to 165 milligrams of aspirin. There are some modifications which we need to be concerned about. When we are using ticagrelor, the aspirin dose should be reduced to 81 milligrams daily. This is sort of a minor point, but you may be tested on this one. So you may want to remember, if you are using ticagrelor, you should reduce the aspirin dose to 81 milligrams. My principle of using these antiplatelet agents or using antihypertensive medications, calcium channel blockers or beta blockers, is to learn one particular drug well, so you know what their contraindications are, what their dosages are, what adjustments you have to make based on their kidney function or hepatic function. In that way, you will be well versed with how to deal with these patients rather than using all the drugs to please someone. The most important person you need to please is your patient and not a drug company. Anyway, here is a class 3B. That means this is a contraindication. This is something you must imprint in your brain. Prasugrel should not be administered to patients with a history of a prior stroke or transient ischemic attack. So this must be in your history. If the patient has a history of prior TIA or stroke, avoid using prasugrel as they have a much higher incidence of intracranial bleeding. So here are two minor points, one major point, another minor point, and that is if you are using clopidogrel, you don't need any adjustments. If you are using prasugrel, you should make sure these patients do not have a history of TIA or stroke. And if you are using ticagrelor, make sure the aspirin dose is reduced to 81 milligrams daily. All right, moving right along, fibrinolytic therapy. If you are at a primary hospital where you cannot transfer these patients within 120 minutes, then we should consider fibrinolytic therapy. The interesting thing is that the fibrinolytic therapy should be administered within 30 minutes from the time of arrival to the emergency room. However, if the patients have been having symptoms for up to 12 hours, it is reasonable to treat these patients with fibrinolytic therapy if the PCI receiving hospital is at a distance which takes longer than 120 minutes to reach. That's a class 1A indication. The next thing is, if these patients who cannot be transferred for any reason to a PCI facility, and if they are having ongoing symptoms of ischemia, if they have a large area of myocardium at risk, they can be considered for fibrinolytic therapy. However, if I am in the emergency room or if I am managing this patient in a primary care hospital, if they are having ongoing ischemia, I would immediately make arrangements for these patients to be transferred to a PCI facility. Because once we administer a fibrinolytic therapy, well, we should not perform PCI within the first 2 to 3 hours, for the risk of bleeding is exceedingly high. Now, here's a class 3B contraindication. Fibrinolytic therapy should not be administered to patients with ST depression except in true posterior infarct. So, in other words, fibrinolytic therapy is not indicated for patients with Stemi, even though they have elevated cardiac enzymes. It is not indicated for patients with the T-wave inversions and ST depressions with positive cardiac enzymes. You need to keep that in mind because you may be tricked with a question saying that this patient has ongoing symptoms, this patient has ST depression, has elevated troponin. They even throw in an EKG and tempt you to use fibrinolytic therapy. Okay, adjunctive anticoagulant therapy with fibrinolysis. You're at a primary care facility where you administer a fibrinolytic agent. The question is, what do you do next? These patients should be on anticoagulants using unfractionated heparin or low molecular weight heparins for a minimum of 48 hours, or in most cases for the duration of the hospital stay. So, in other words, you have already given the fibrinolytic therapy, then these patients must be, this is a class 1A indication, maintained on anticoagulant therapy for a minimum of 48 hours. Either you can use unfractionated heparin or you can use low molecular weight heparin such as enoxaparin. That's what I have used for the most part because it's easy to administer. The dosage can be adjusted based on age, weight and creatinine clearance, and it is convenient. We don't have to measure the PTT, and it works as good as unfractionated heparin. Now talking about coronary artery bypass for patients with Stemi. Class 1B indication says urgent coronary artery bypass surgery is indicated in patients with Stemi and coronary anatomy that is not amenable to PCI, who have ongoing or recurrent ischemia, cardiogenic shock, severe heart failure or other high risk factors. So what it simply means is that if you have a patient who cannot undergo PCI, or if you have a patient with more complications than a simple myocardial infarction such as shock, heart failure, they should be considered for coronary artery bypass surgery. Also, Class 1B indication is if you have a patient with a myocardial infarction with a complication such as papillary muscle rupture or ventricular septal defect. If they are going for surgery, they should also undergo coronary artery bypass surgery for the coronary occlusion. Timing of urgent CABG in patients with Stemi and antiplatelet agents. We talked a lot about using antiplatelet agents as soon as possible and how long we need to use them and what drugs we need to use. But as I said, if these patients have to go for surgery, then the dilemma comes, what do we do with the antiplatelet agents that we have already given or we are about to give? All right, aspirin should not be withheld before surgery. If the patient has been started on aspirin, you continue with the aspirin even during and after the surgery. If this patient has received clopidogrel or ticagrelor, it should be discontinued at least 24 hours. But in reality, when we talk to patients with who are going for elective procedures or endoscopy, we tell them they need to stop the Plavix for at least 4 to 5 days before they go for any procedure, because that's how long it takes for the body to regenerate new platelets to prevent any bleeding. But however, when a patient with a STEMI is going for surgery, we don't have much time, and here it says at least 24 hours. That's a 1B indication. Similarly, if you are using a short-acting intravenous 2B3A receptor antagonist such as eptifibatide or tirofiban, they should be discontinued for at least 2 to 4 hours before urgent coronary artery bypass surgery. This relates mostly to patients who are in the cardiac catheterization lab, who are receiving GP2B3A inhibitors during coronary intervention. And if for any reason these patients have to go for surgery, you have to hold off these 2B3A receptor antagonists for at least 2 to 4 hours. Now let's move along beta blocker. Here it says 1B indication. Oral beta blockers should be initiated in the first 24 hours in patients with the STEMI who do not have the following contraindications: signs of heart failure, low output state, increased risk of cardiogenic shock, or contraindications to use of beta blockers such as PR interval of greater than 240 milliseconds, second or third degree heart block, or active asthma or airway disease. So there are a lot of contraindications to using beta blockers. We need to be very prudent in using beta blockers because this is not a class 1A indication, this is a class 1B indication. You use beta blockers where it is most appropriate. If you have a hypertensive patient with a tachycardia and no evidence of significant heart failure, then it may be reasonable to use beta blockers. But if you have a patient with pulmonary congestion and a low cardiac output, or if the patient has higher degrees of AV block, then beta blockers should be withheld until there is a clear understanding of what the patient's overall condition is as time passes. If these patients are on beta blockers, they should be continued during the hospitalization for all patients with STEMI and with no contraindications to their use. So if we start these patients on beta blockers, it is reasonable to continue these patients on beta blockers not only during hospitalization but also in the post-hospital phase depending on their condition. You may be using beta blockers for control of their blood pressure. You may be using beta blockers to control their atrial fibrillation rate, in which cases it is reasonable to continue these beta blockers. Now let's talk about Renin-Angiotensin-Aldosterone system inhibitors. Class 1A indication is to start all these patients with STEMI as long as their blood pressure is reasonable on ACE inhibitors within the first 24 hours, especially if these patients show evidence of heart failure, low ejection fraction, unless there is a contraindication. If these patients are not able to tolerate ACE inhibitors, then the next choice would be to use ARBs in patients who cannot tolerate ACE inhibitors because of cough. Class 1B indication is to use aldosterone antagonists in patients with STEMI who have evidence of heart failure with a ejection fraction of less than 40% or history of diabetes. This is an interesting finding because in patients with chronic heart failure, we don't introduce aldactone antagonists until they are in class 3 or class 4 heart failure. However, when we are dealing with a STEMI patients, if they have evidence of heart failure, if their ejection fractions are less than 40%, we can put these patients on aldosterone antagonists in the early stages of the acute myocardial infarction, and especially if you are dealing with a patient with diabetes, they must be started on aldosterone antagonists much earlier than we would in a patient with chronic heart failure. Let's move on. Lipid management. All patients with acute STEMI or NSTEMI, here's a class 1B indication that we should put them on high intensity statins as soon as possible and continued on indefinitely. And here's a class 2, which I don't think we need to worry about it. That is, if we can obtain a lipid profile in these patients with STEMI within the first 24 hours. But the goal is to bring the LDL below 70. So it is prudent to start these patients on high intensity statins and then reduce the dosages if needed based on their lipid profiles. Treatment of cardiogenic shock. Class 1B indication. Emergency revascularization with either PCI or coronary artery bypass surgery is recommended in suitable patients with cardiogenic shock due to pump failure after STEMI, irrespective of the time delay from onset of symptoms. So if they are having ongoing symptoms, or if they are having evidence of pump failure or cardiogenic shock, they should be considered for PCI or bypass surgery, irrespective of the time of onset of the myocardial infarction. Now again, we have 1B indication. In the absence of contraindications, fibrinolytic therapy should be administered to patients with STEMI and cardiogenic shock who are unsuitable for PCI or CABG. So if you are in a primary hospital where you have no PCI facility, no cardiac surgery facility, it is reasonable to administer fibrinolytic therapy to these patients with a cardiogenic shock, with the hope that by dissolving the clot, improving the circulation, maybe you can restore some of the myocardial function and hopefully salvage myocardium and life. Implantable Cardioverter-Defibrillator therapy before discharge. This is a very important concept. We should differentiate from patients receiving ICD or defibrillators for low ejection fraction. In the presence of an acute myocardial infarction, ICD is indicated before discharge for patients who develop sustained VT-VF after more than 48 hours following a STEMI. This is a very important concept because you are going to be tested on this particular concept if you are dealing with a STEMI patient, and after 48 hours where the primary VFib period has passed, if the patient develops VT or VFib, they should be receiving ICD before discharge. Then they stick in a little footnote here, provided the arrhythmia is not due to transient or reversible ischemia or reinfarction or metabolic abnormality. If you had a patient with a STEMI, with single vessel disease, you put in a stent and you are confident that the stent is functioning normally, and 48 hours later, if this patient gets VT or VFib, that patient should receive an ICD. But if you are having a patient with triple vessel disease, then we can perform chemical stress test to see if there is evidence of reversible ischemia in the non-treated arteries to see if they are accounting for ventricular fibrillation or tachycardia. But this is getting a little more complicated than what we want it to be. Pericarditis after STEMI. This is where they are going to trick you with the most common drug that we use for like viral pericarditis, which is a class of anti-inflammatory agents. But in a patient with a STEMI, aspirin is recommended for treatment of pericarditis following STEMI. Class 1B indication. If aspirin doesn't work, then we have class 2B/C indication, and that is acetaminophen, colchicine or narcotic analgesics. And look at here, contraindications. So this is something you need to keep in mind. If you're dealing with post-MI pericarditis, glucocorticoids and non-steroidal anti-inflammatory agents are harmful to patients with pericarditis after a STEMI. Why are glucocorticoids and non-steroidal anti-inflammatory agents harmful in STEMI patients, period? Because these anti-inflammatory agents and glucocorticoids interfere with the healing process of the myocardium, and that can lead to ventricular remodeling, which is unfavorable. That means there could be ventricular dilatation because of interference with the inflammatory repair that is going on at the infarct zone. All right, so ladies and gentlemen, here is anticoagulation. This, I think, is the last slide. Let's talk about anticoagulation in patients with STEMI. When a patient with a STEMI comes who already is on anticoagulation, such as warfarin or other drugs for atrial fibrillation, or they have a valve replacement and they are on anticoagulation, then a class 1C indication is to continue these patients on anticoagulants. But there's a new indication for use of anticoagulants. If there's a new onset of atrial fibrillation and you want to use anticoagulants, then we should follow the same principles we do in general population by looking at their TATS-2 score. If it's greater than 2, they should be started on vitamin K antagonists, namely warfarin, for management. But you have to remember, patients with STEMI are already receiving aspirin and an antiplatelet agent. If we add a third agent, which is, for example, warfarin, then these patients are going to be on triple anticoagulants, antiplatelet combination. This triple antithrombotic therapy should be very carefully monitored, and the PT-INR should be kept to between 2 and 2.5 so that we minimize the risk of bleeding. So ladies and gentlemen, here's one more thing about the anticoagulation. It is reasonable to use anticoagulants in patients with STEMI who have a left ventricular mural thrombi. And similarly, we have a lower indication of putting patients on anticoagulants who have anterior apical akinesis or dyskinesis. Anyway, when we use anticoagulants, we want to make sure their INR is between 2 and 2.5, who are also receiving dual antiplatelet agent. Finally, initially reduced left ventricular ejection fraction who are possible candidates for ICD therapy should undergo re-evaluation of ventricular ejection fraction 40 days or more before they are considered for an ICD placement. This is what I was talking about when I mentioned placing ICD for a VTAC VFib happening 48 hours after coronary intervention for a STEMI patient. However, if there is no evidence of any significant ventricular arrhythmia, if the patients have indications for ICD placement because of low ejection fraction, that needs to be re-evaluated 40 days after an acute event to see how much of the function improves, and based on the left ventricular ejection fraction, we can make a decision at that time as to what is the most appropriate way to treat the patients with reduced left ventricular ejection fraction. So ladies and gentlemen, this is a long simplified version of ACC/AHA STEMI guidelines 2014, which is the most recent one for year 2017. But the ACC slide presentation had 126 slides. We have cut that into 25 slides. I hope this presentation will shed light on how you manage your STEMI patients based on the most recent ACC/AHA guidelines. So no one would question about your medical judgment if you follow the ACC/AHA guidelines. I am Dr. Nik Nikam. Thank you very much for watching this presentation, and please do subscribe to our YouTube channel, and we will see you next time. Thank you so much.